Our next speaker is, pronunciated in the right way, is Jameela Salman. Is that right? Okay. She's a medical doctor, and I think she will also give a talk about from the viewpoint of a medical doctor. And she is working at the Arabian Gulf University. Then she moved to Pennsylvania and the Salman University, the Temple University, and the Yale University in New Haven. And she is an expert in internal geriatric medicine and infection diseases. And she also cooperates with you, medical. We are looking forward to your talk.
Thank you so much. Thank you. Good morning, everybody. Thank you so much for the organizing committee for inviting me to be here. And I think this is from one clinician to another clinician. This is probably most of the presentation is my point of view and what we have seen in real life data and some of the important things that we are seeing as a clinician. And really most of the information that we use as a clinician, what we have as a researcher and scientist, we take it, we present it, we have guidelines, we submit it to the policymaker to make change, because we really, where we work is our patient. It's really what matters at the end. Is the infectious diseases, is hospital-acquired infection, whatever the type, and if we can decrease morbidity and mortality related to it. So I think some of the talks that has been this, the three presentation actually before me, gave really set the scene for what I'm going to go through my presentation. And this is from the other end, really the other end. I've been working as infectious diseases, covering immunocompromised patient, heading infection control in different hospitals, governmental, private, putting guidelines and recommendation in the region, coming from Bahrain, Gulf countries, and the Middle East region, and representing even in WHO. So this is where it comes. So when we talk about the antimicrobial resistance, this is one of the main problems that we don't know where we are going. We know it's increasing, we know it's bad, and the prediction actually it will get worse as it's getting worse. Whatever initiative has been done internationally, whether WHO, talk about even CDC, and I'll share some of the numbers, has been really successful to a certain degree. And I thank you so much for the previous presenter who said, we never make hospital-acquired infection zero. It's really, there was one point we are talking about zero tolerance, but believe me, it's really very hard to do it, very, very hard to do it. So when we talk about infectious disease, the prediction, if we keep doing what we are doing, it will be again the #1 cause of mortality internationally, like the pre-antibiotic era. And that's the main problem. It's not just a problem because we are talking about patient die or one patient. It's really a very important topic related to economy, SDGs. It's very important. The top leaders, all the countries, they are working in the antimicrobial resistant agenda, which is the AMR agenda, because really we are facing it. Why it does matter for all of us, for us as a clinician, and for all of you, probably a relative, a friend that's been admitted to the hospital and get a hospital infection where they have something related to it. So it's really a serious illness. Patient will stay longer, and I'm sure coming from our region, really sometimes it's hard to find a bed to admit it because we have long admission. Disability, we have also stories, excess death and mortality. Infection, actually, most of the hospitals in our region is either #1 or 2 or 3rd number cause of mortality in the hospital. So it's really a serious issue, and really it has a lot of financial burden that really compromise the way we are, even providing our health services. This is, data that's, not from our region, but to tell you it's really costly. We are talking about billions of dollars. This is, most of the data actually from the United States, from Europe that we are referring to, because in another challenge in our region, it's really to really calculate the cost of infection and how you can really look for it. So that goes back probably to the previous presentation, and that's really very, very important. You want to control all of this, those multi-drug resistant organisms, and I can keep talking about them the whole day because really they are horrible. They are increasing. The rate of infection increasing, the resistance increasing, and not much antibiotic in the pipeline that can do this. Really not much. We are suffering. We have people today in the hospital, they are dying of hospital infection that we don't have a solution. We combine antibiotic that may work and may not work. So the basic elements that you have to work with to make it happen and decrease those hospital-acquired infection is infection control with all the measures and the utilization of antibiotic, which is different here. You know, I've been working with antimicrobial resistant and stewardship for years. Believe me, it can do some impact, but not really huge impact. So it's infection control and other measures. These are data just to give you this sense of information. This is from CDC. This data from 2019, really prevention work. And this is probably goes back to endogenous versus exogenous, because prevention from endogenous, it's there. Probably we saw 60% infection come from our body, but really not much to do about that, what we have in our body. We have to go to the exogenous, where we can do some difference. Even if it's minor, I will take it, because this is where we can make a difference. So within the CDC data, it really decreased the rate of infection, but still it's costly to the health system. And you know what happened? When the COVID-19 pandemic, and I'm really very glad that the other presentation today, brilliant presentations that has been done, it really mentioned the pandemic issue. So the pandemic COVID-19 came and disturbed the whole thing that we were doing as infection control, infectious disease, antimicrobial stewardship. We were trying to decrease the MDRO, the resistant, but then the pandemic came and disturbed the whole work we are doing. And again, what happened is increase in the hospital-acquired infection, in the resistant pattern, and this is what happened in the United States. You saw the success happen, that happened up to 2019, and again in the pandemic it increased. So pandemic is there, and you know that everybody's talking about disease, X, when it's coming, it's the flu or other, who knows when it's coming, but it's coming. 1 year, 5 years, who knows? But according to what we are seeing, we've been working in pandemic preparation with the WHO, we are seeing it more frequent. With the climate change, what we are doing as a human is not good, but it's coming sooner than what we think. In our region, with publication, because data is a source to see what's happening, to know what you are doing is evidence-based. We are, scientists, clinicians. We look for evidence-based. We love it, whether it's the whole story or part of the story, but we love it. And this is a paper from the region, our region, the EMRO region is called, which is the Middle East. This is the rate of the resistant bugs that we have. It's too much. It's beyond, it's probably one of the highest in the country, especially for the gram-negative organism. If you talk about Acinetobacter, Klebsiella, E. coli, we are not talking about, ESBL resistant. We are talking about pan-resistant organism that across the region, and the darker is your country, the higher. That's in our region. And they were looking for no much data, no surveillance, we don't know what's happening. We need, and this is really a flow for a lot of researchers, to do some good. This is very important because they were comparing the infection in the hospitals for low-income country versus high-income country. And you go to low or middle-income country, much, much higher. So if you're looking for NHS data or other system data or NHS, which is international, you will see for a VAP, which is ventilator-associated pneumonia, it's a 2-digit number, not a single-digit number. So we have a long way to go to be able to decrease hospital-acquired infection in our region. This is where it becomes very important to have anything. If you tell me that this will add on to what we do as infection control, it's very important. So COVID-19 really gives us a lot of sense of what we are doing in the hospital as infection control. We have sicker people, they stay longer, they start moving between them, because this is where infection control practice didn't help much, really didn't help much, because we have outbreak of other MDRO, and we really grown the environment because we could not. We have patients, crowded area, a lot of machine, ventilator in the same room. Cleaning them between patients running in the pandemic was not possible actually. So we implemented all infection control measures, but again, I hear that in other hospitals don't have much outbreak. We have outbreaks every 6 months, every 1 year. Major outbreaks actually, especially neonatal ICU probably. And this is probably reflecting another side where in another region we have issue even implementing the basic infection control. So infection control, it has really it works when you implement all those personal protective equipment. You do what you have to do. Cleaning is very important, and this is probably, it has a direct and indirect increase in the cost. What's really painful to all of us, we know that most of these infections that we get, or the patient gets, are preventable. How much we can decrease, we don't know. And this is really, and I think presented like, the source, mode of transmission, and the chain of infection, how it's being transmitted. It has to be stopped, or actually is at least decreased at one point, from surface, from hands, from wherever we touch, it should be decreased. So our learning, really lessons from all infection control measures regarding hospital infection is that we have to do a lot, but environment is a basic thing. When we go to the updated guidelines of infection control, hospital infection, go to SHEA guidelines and everything, a lot within the new guidance 2022, a lot about the environment, cleaning, disinfecting. So it's very important to mention, this is regarding C. diff. C. diff, one of the things that's pretty hard to get rid from the service. So when you have it, you have to do a lot, and terminal cleaning, we call it. Patient environment is major, we have to do much. So where is really it comes? I'll just give example, because I know that it's been raised before. Does UVC helps with surgical site infection or any hospital infection? Okay, surgical site infection is one, probably it's usually like the third type of hospital infection in most of the hospital. It varies from hospital to hospital, country to country, costs billions of dollars, and actually more contamination you have airborne on the service, you have more surgical site infection. Usual filters, HEPA filters, believe me, all the germs can pass through them within the OR. If you have filtration, we have the 20 exchange air in the OR. Believe me, it's not good enough, and it can decrease only by 30%. And this is where UVC come on board to give us help. Regarding, probably you saw within the three presentation earlier, we are talking about the UVC, which can help not only in the hospital, even in other buildings. And this is the guidance from the American Society of Heating, Refrigerated Air Conditioning, and they are recommending UV in general to add some protection, some improvement in the quality of air that probably we can really utilize. UVC awareness, probably you hear the numbers, you know it, you are scientists better than me in that. So I'm talking about the range which is really harmless, 200 to 230, and this is where the new technology is at 222 because it's safe. The first presentation, I think, for Dr. David, you mentioned very well. It's really good, it's safe. The wavelength you are talking about will not damage the eye, okay? It's safe, we have some information about it. The skin also will not, will not be harmful to the skin. And actually, it has a double work of those bacteria or viruses will work on the protein or DNA and RNA. So we are targeting, to some extent, what we want to target. So that's the point we are looking forward. So what's the evidence that probably it can help with hospital infection? And this is regarding UV in general. There are studies that when you use them in operation theater, it can decrease the colonization or in the service, what's happening there. This is another will decrease even type of organism. This is about Staph aureus, and you hear the name earlier that we have Staph aureus, the other MDR. It can decrease it, and there are several publications. There are others actually. Whether in the service, it can decrease. The question that most of the clinicians will ask, though the decrease in the service, will it reflect and decrease your hospital infection or not? That's another, and we need actually more studies. But what we found right now, if you have less colonization, okay, less number of colonies or organisms in the services, that probably will help to decrease to a certain degree your hospital infection. I'd like to mention one thing, and this is very important. I really agree with the previous presenter. UVC will add to what you do. If you are doing good infection control, you have a good infection control program, that should help. So this is regarding one article that was published to enhance terminal room disinfection. If you've been working as infection control, we have one of those tough organisms. We ask the infection control and the cleaning, people to do a terminal cleaning, where we use different actually methodology. In this actually presentation, study, they added UVC to it, and they found it helps in decreasing the colonies and the number of organisms. This is another study that was done, but that was combining UVC with ozone treatment and actually decreased the healthcare infection in one of the studies. This is another one also for COVID-19, and this is they were looking for as infection control. We ask people to clean the services, so porous services and non-porous, and we have really problem in having good cleaning. Even if you ask your staff in infection control to go and do terminal cleaning, believe me, go and test the service. there will be still organic. It's hardly terminal cleaning. It's very clean, and you have really to admit the patient in a clean surface. In another study, we used the ultraviolet. See, this is actually a systemic review that will look at the efficacy and safety. They found it's really safe, not much really damage. They asked for not much actually side effects, and they asked for further studies. And this is really one of the recent, one of those was just published in June 2024, actually just recently. And this is about evaluation of the wall-mounted ultraviolet light technology and really combating Candida auris. Did you hear about what's happening with Candida auris internationally? It's the new nightmare for us. If you're working in a hospital, it is there. It's been there, but after COVID-19, Candida auris is in all the hospitals. In the hospitals, I work because I was here even the COVID-19 facilities in my country. We have a couple of wards and floors, up to 50 to 60 patients positive infected with Candida auris. Treatment, resistant, hard to be treated. Even if you do the best cleaning methodology, is still there. If you ask any hospital in the world that they have Candida auris, you will know that they are fighting it, and it's the new nightmare for all of us. So this study actually, they try to see if it can affect the level of the polarization or on the surface of the Candida auris, and the far UVC technology was used for. And if you see, this is where it was used, and this is with the control, it decreases within hours. That contamination of Candida auris. As I said, in our hospital, we started with 1 patient within the COVID-19 pandemic, then 2, then 3, then 4, we ended up with 68 patients in the hospital with Candida auris. And we cannot make it this. We cannot. We tried all of whatever cleaning methodology we have, but still there. And in the same study, they were looking to different actually materials, steel, plastic, and others like glass, and it works in all of them. And the high-touch services. You know what's horrible actually within the hospital setting in the patient room? All those the blood pressure, machine, the stethoscope you are using. How you can clean them and how much you can actually clean with the usual cleaning methodology? Not much. Not much. All the study will prove for you that you can do good, but you cannot really decrease it to a degree that is safe for the patient to come in the room. So it really works, and it's very helpful. There are some evidence for efficacy and safety, but really, as physician, we want to see what's happening in my hospital if I use it. So what's happened? This is a technology that has been developed, by really well-known universities. It has been mentioned here by the CDC. They were really talking about it. The WHO, they were talking. It's in compliance with ISO guidance. But what makes the difference for me as a clinician, infectious disease, infection control, real world data. We love to see real world. We said we are evidence, we base our work in evidence, but we love to hear it, and to see if it works. These are data from Denmark, because this technology was started actually, and in Denmark, this is one of the hospitals, they used it and actually saw 90% reduction in bacterial load of the services. This is one hospital. In another hospital, in Kolding Hospital in Denmark also, they use it within the COVID-19 pandemic. They use it as sample in one of the wards. Then they have to reach in all the hospitals because they were really amazed by the results they found. One interesting area, if you work in infection control, if somebody told you clean inside the ambulance, did you enter inside that ambulance? How complicated and everything is packed? No way. Any cleaning way you are doing with any material, you clean it, but it's really hard. So they used it, and they found that it really decreased the contamination inside the ambulance, and I think it was used at the national ambulance system in their country. Coming to my region, and this is the real world data that we have. I just put them up so you know what countries I will talk about. This is the Gulf countries, and I talk about example from Saudi Arabia, from Bahrain, and United Arab Emirates, because in these countries actually we use actually, we try to pilot it to see, because for us at the end we say, this is a new technology, and new technologies come all the time. We want to see if it's help, it will decrease, what we have in our services. So I'll give you some examples. This is one of the major hospitals from Ministry of Health in Saudi Arabia, And actually, I know it's too much data, but if you look, when they started with all organisms, when the samples has been taken from the service, and then taking the service later, it's been negative, most of the services. This is another 2 hospitals from Saudi Arabia. This is, we know, from private sector. One hospital is Dr. Jameela Hospital, another Prince Sultan Humanitarian Hospital, and at the same thing. A lot of organisms in the service. And I'm telling you, these are hospitals, they're really good, they have good infection control program, and they couldn't do it the usual way. This is too crowded. Don't look in the details. This is the major hospital I work. It's a government hospital. It's 1,200 bed hospital, and this is where we have the ward for Candida auris and all isolation ward. If you go for the first line in all of them from different services, in one sample, we get 6 to 7 microorganisms. It's horrible, it's contaminated. We do all the infection control measures, but when we piloted and we started the UVC, we found with repeated sampling, those for the same area, it decreased. So we have some evidence that can decrease the load of the microorganism on the services. This is from United Arab Emirates. There are a couple of hospitals here also, Sheikh Khalifa Medical City, and from one of the lab in Dubai. And the same thing they saw before they put the device, and after they put the device, there was no growth. In another hospital also in United Arab Emirates, they found also there is decreased contamination from organisms like Staph aureus or others to no growth after they put the device in. So it really makes a big difference for all of us when we are practicing. And really, as I said, as infectious disease and infection control, we've been working, we try our best, infection control has been there, and we know the evidence behind all the infection control measures, cleaning, hand hygiene, PPE, waste management. But it's not giving us the results we are looking for. So what UVC actually can help with is, probably you can put it there in the room. It's safe, as we said, to the eyes and skin, so it's continuous, not disinfected. It's unobstructive, so you don't have to put a machine, because we have, like, the previous UV, disinfecting machine, we have to take them to the room, empty the room, leave the room like 2 to 4 hours after, we clean it, and then give the patient back. So that was a loss of like 6 to 8 hours before we can utilize the same room. And then it's autonomous, it's working, it's a smart built-in. You can put it within the rooms and have it in the hospital, working currently in, and it really helps in decreasing the outload of microorganism. And we are aiming, as physician at the end, to have decreased hospital infection and morbidity and mortality related to it. So surgical site infection is really costing, and so I showed you a couple of the examples where it can decrease the SSI surgical site infection. So for me, even if you save a life, or that cost, the surgical site infection, it's really cost effectively calculated, but we need more evidence. We need to do more actually to prove it with evidence base. As I said, as a clinician, we love evidence base. So if you show me data, work with it, and we could come with some suggestion. So everything else, after patient saving lives, it's a saving. So some take home messages here. We need to continue to evolve in science. This is where that you from your work really help us when we go to the bedside and try to save lives. Really has to be there. If we are comparing it to other cost-effective methodology, like chemotherapy, which costs it's very expensive medication, how much, or orthopedic screws or surgery, how much it really, or robotic surgery is coming, very expensive, whether it's cost-effective or not. But really, my overall opinion, we should be doing more for infection control. We are not doing enough. We need more. We need technology actually to help us. You maintain your infection control program, that's will say there's evidence behind it, and we need to add on. UVC can help, it will add. It cannot penetrate the biofilm, it cannot penetrate what's out there. It has to be cleaned first and use your UVC with it. So that helps. And the last slides actually, and I think that goes, this is how we think as scientists or as a clinician. There are a lot that we know, and I said, infection control measures, all those evidence that we know them, we know the science behind it, how much it increased. What some might know, this is the new evolving science where we have to keep up with all those data and research. And there's some what you really should know, we have to have more about hospital infection and how we can decrease them. And something probably you never know, and I think it was mentioned in the previous presentation, something we don't know from which the source, from where they come, but it's there. The organism is there, infection happen. So the question is for all of us here who are working, are we ready for the next pandemic? From my experience, we are not ready. As you know, closer